Welcome to my channel everyone. Today we will be discussing malabsorption syndrome, but let's start with something you love. Think about your favorite meal, a burger, french fry and Coca-Cola. Okay. Now once you eat this food, digestive juices like pancreatic juice, saliva, bile and other enzymes work on it, breaking it down into absorbable nutrient like glucose, amino acid, triglycerides. These nutrients are then absorbed by specialized cell in intestine called the enterocyte, okay, which transfer them into the bloodstream. This is the normal process of digestion. Maldigestion refer to the condition where there is a deficiency of digestive enzymes, so food isn't broken down properly. On the other hand, malabsorption is when the body cannot absorb or transfer this nutrient from the intestine to the blood vessels. Now, what happened to unabsorbed food left in the intestine? So, first of all, carbohydrate that aren't absorbed cause the gas, bloating, and diarrhea. Okay, flatulence. Fat that aren't absorbed lead to the steatorrhea, which means the foul smelling oily stool. Then unabsorbed proteins result in the protein deficiency, which reduce your oncotic pressure, which retain fluid, and after that decrease in the oncotic pressure, you will develop the edema. Vitamin A and vitamin K deficiencies lead to the night blindness and bleeding tendency, respectively. Iron, vitamin B12, and folic acid deficiency lead to the pallor or anemia. Okay, and mineral deficiencies like calcium and magnesium will lead to the bone pain and the muscle pain, all this pain. So malabsorption, I told you that inability to absorb the nutrient from the lumen of the intestine into the enterocyte and from the enterocyte to the blood vessel. This is called the malabsorption. And malabsorption with this clinical manifestation which I mentioned here are called as the clinical manifestation. With this manifestation, malabsorption is called as the malabsorption syndrome. Okay, so now we will discuss the how to approach and what are the malabsorption syndromes are there. So you know the three stage of the digestion. First one is the luminal phase, then the mucosal phase, and the third one is the post absorptive phase. So here you can see the cross section of the small intestine, and you can see the lumen, then the mucosa, this one is the mucosa, and the blood vessels between the two layers of the muscle. First we have the luminal phase where the digestion take place, and a defect in this phase can be caused by the several conditions including the hereditary pancreatitis, chronic pancreatitis, tropical pancreatitis, hereditary absence of pancreatic lipase, a lack of bile acids and salts, then lack of gastric juice, and the intrinsic factors hypermotility due to the infection, hyperthyroidism, intestinal anaphylaxis, congenital lactase deficiencies, and congenital sucrose maltase deficiency. Next phase is the mucosal phase defect, and here nutrient are absorbed where the nutrient phase are the absorbed in mucosal phase, and defect here can result from the conditions like the celiac disease, most common. They are followed by the tropical sprue, autoimmune enteropathy, giardiasis, parasitosis, eosinophilic duodenitis, microscopic enteritis, cystic fibrosis, drug air, graft versus host disease, small intestinal lymphomas, then infantile ulcerative colitis, microvillus inclusion disease, and tufting enteropathy. Next phase is the post-absorptive phase, and the defect leads to the lymphadenitis, Whipple disease, A beta lipoproteinemia, hypo-beta lipoproteinemia. Okay, so now we will study the approach. So, history and physical examination are the most important first steps. You should gather key detail like the age, sex, weight, and height of the patient. History of symptoms such as diarrhea, steatorrhea, flatulence, abdominal distension, pallor, night blindness, paresthesia, bone pain, all are required. Drug history, which is crucial for drug induced enteropathies. Organ transplant history, important for the diagnosing the graft versus host disease. Then the family history, which helps identify the hereditary or congenital enteropathy. Travel and the infectious history, especially relevant for the condition like the tropical sprue. Okay. Next is the serology, which we will discuss in detail soon. For example, anti-tissue transglutaminase and the anti-endomysial antibodies are used for to diagnose celiac disease. Serum studies like vitamin B12, vitamin A, vitamin K, and folate level, along with the amylase and lipase, help identify the pancreatic enzyme deficiencies and clinical manifestation produced by these vitamin deficiencies. And also we can do the antiparietal cell antibodies for the pernicious anemia diagnosis, anti-enterocyte and anti-goblet cell antibody for the autoimmune enteropathy, and we can measure the total protein level. Next is other laboratory tests, like you can do the carbohydrate malabsorption test, D-xylose absorption test, lactose tolerance test, breath hydrogen test. Then for the fat malabsorption, you can do the fecal fat determination by the 14 carboxytriolene brick test. Then genetic test you can run for the condition like the congenital lactate deficiency, where the LCT gene is mutated and the CFTR gene mutated in the cystic fibrosis. And you can run the sweat chloride test for the cystic fibrosis and electron microscopy for the microvillus inclusion disease. Next is endoscopy, where you can check for the mucosal fold anatomy, and you can take the biopsy from the that affected area, so you can send it to the final histopathological diagnosis. And next we will start with the mucosal phase defect. First and most common is the celiac disease. Why we are discussing the mucosal phase defect is that in the first, because luminal phase defect are all about the deficiencies of the enzyme. There is no specific symptoms and histopathological features or radiological features or the finding, okay, special finding. So you just do the biochemical test and get the result and do treatment. But in celiac disease, tropical sprue, like luminal phase defect means mucosal phase defect and the post absorptive phase defect, the differential are very narrow, and you are not able to differentiate one condition from other, and all condition having the different treatment. Okay, so we will discuss the mucosal phase defect and post absorptive phase defect here. The first is the celiac disease. You can see the prevalence of the celiac disease here. 0.5% in the North America, 0.4% in the South America, 0.5% in the Africa, 0.8% in Europe, 0.6% in the Asia, and in the India you can see the most common region affected by the celiac disease is the North Indian region. So here 1.4%. And next is the this is the autoimmune disease in the genetically predisposed individual. What is the meaning of the genetically predisposed? It is due to the HLA-DQ2 or HLA-DQ8 genotype. Okay, it is higher in the children than the adult. So now gluten sensitivity, also we call this disease as the gluten sensitivity disease. So where the gluten come from? The gluten come from the wheat, rye, barley, and oats. So in wheat, gliadin and glutenin are the gluten peptide. Then the siccalin in the rye, hordein in barley, avenin in the oats, all are the gluten peptides. They are resistant to digestive enzymes, and these undigested gluten peptides are now exposed to the enterocytes of your small bowel. Okay, and what they will do is that they enter into the enterocyte. They have two paths. They can go between the two cells. This is called the paracellular pathway, and this one is the transcellular pathway. So here, if for the paracellular pathway, your tight junction should be leaky. So either you have some disease or some genetic disorder which makes your tight junction leaky. Okay, so this will enter into your paracellular pathway. Here the immune cells are there, so it will expose to the immune cells, and immune cell will react like, oh my god, this is from the outside, so we should make the auto antibodies against this substance. So the auto antibodies are formed against this gluten. So next step is, if you are healthy but genetically predisposed, then this gluten will carried by the tissue transglutaminase, and this complex will present to the CD4 T cell, okay, by the help of the HLA-DQ alpha beta. And after the activation of the CD4 T cell, this CD4 T cell will stimulate, or this CD4 T cell will activate your immunity against the gluten peptides with the help of the production of the anti-tissue transglutaminase antibodies. Okay, now what this antibody is, a diagnostic antibody, so you can detect it in the serum, and this antibody cross react with the dermal antigen. That's why the patient of the celiac disease showing the dermatitis herpetiformis. Okay, and it also damages the other organ also. So now the histopathological finding, you can see these are the my hand made diagram, and biopsy should be cut at the 3 to 4 micron. Okay, you can do the CD3 immunohistochemistry to count intraepithelial lymphocyte. But when you are counting the intraepithelial lymphocyte, you should must remember that 500 enterocyte counted across the 5 oriented villi. Okay, this is the villi. Okay, and you have to count intraepithelial lymphocyte here only. Okay, so Mars give 5 stage. The first stage is the pre-infiltrative stage, where everything is normal. Okay. So what happening here is the lymphocyte is going upside, because these enterocytes having the gluten, and this gluten activated the immunity. So all these lymphocytes are going upside, and here you can see the intraepithelial lymphocyte, so many lymphocytes here. So if there are the more than 40 intraepithelial lymphocyte per 100 enterocyte, then it is called the ileosis. Okay, and this is called as the infiltrative stage, type 1. Then what happen is that in type 2, this is infiltrative plus hyperplastic stage. Here ileosis is there, this increased intraepithelial lymphocytes are there, but also the new feature is the crypt hyperplasia. Okay, and after that, in stage 3, means type 3 of the Mars, where the destructive stage will come, and here all these ileosis, then the crypt hyperplasia, and next step is the villus atrophy. You can see the height of these villi and these villi, there are some difference. This is called the villus atrophy in the form of the villus clubbing, okay, villus flattening. Okay, and the last stage or type is the atropic hypoplastic stage, where the atropic and thinned out flat mucosa will be seen, and here you can see the crypts are now atrophied in comparison to these. So you can compare this handmade diagram with the original histopath images, and this is the normal pre-infiltrative stage. You can see the cloth shaped villi, which are the sign of the villus atrophy, and you can see here the intraepithelial lymphocytes increased, and also the crypt hyperplasia. So you can correlate this finding with the Marsh 3. Okay, and this one is the flattened villi, no villi at all. This is a flat mucosa, atrophied mucosa. Okay, and you can see the crypt atrophy here. So this is the type 4 of Mars. Now you can correlate this histopath image with the clinician's endoscopic images. So this is the normal villi look like. Then in stage 2 or 3, there are the scalloping and the fissure formation in the mucosa. Okay, and in the final stage, advanced stage, there are loss of mucosal fold. So this is the modified Mars Oberhuber classification for the celiac disease diagnosis in on the histopathology. So same as earlier I discussed, but here the modification in this type 3. Here type 3A, B and C based on the villus atrophy. If the villus atrophy is mildly atrophied, then villi is mildly atrophied, then 3A. Marked atrophy, you can see, then 3B. If there is a complete atrophy of villi, then it is a 3C. So you learn about the clinical examination, serology, endoscopy and histopathology of the celiac disease. So this is a multidisciplinary approach. The next disease is the tropical sprue. So what is the tropical sprue? So post-infective diarrhea with the malabsorption of at least two unrelated substances, predominantly found in the Central America, Southeast Asia, among the traveled to these regions. So epidemic regions are the India, Northern South America, West Africa and the Caribbean island. So what is the association with the genetic? So HLA AW19 haplotype are at the risk. Okay, nobody know the exact pathogenesis, but I am explaining from the detail I gathered from some articles. So here you can see the infection of the GIT by the Escherichia coli, Klebsiella pneumoniae and Enterobacter cloaca. This will do the this will do is the microbial dysbiogenesis. So your normal microbiome will be disrupted, and they will no longer to able to digest the food at the same pace. Okay, so disturbed gut mobility is there. So there is increased food transition time, means from the esophagus to rectum, this time is increased. So what happen is that the small bowel stasis will occur here. So you can see the small bowel stasis means this will lead to the bacterial overgrowth. So these are the black one is the bacterial overgrowth, and this bacterial overload will lead to the activation of the immunity, and it will create the inflammation, cytokine induced immune activation and attack. And exactly like the celiac disease, it will look like on the histopathology: villus flattening, crypt villus ratio alteration, then the ileosis I told you, then the crypt hyperplasia. All these will exactly similar to the celiac disease. So you have to differentiate tropical sprue from the celiac disease by various means. You can see the endoscopic findings are different from for the tropical sprue and the celiac disease. So here the normal endoscopic finding is the more common finding in the tropical sprue. Okay, and here the main characteristic point is the ileosis. So here the ileosis in the tip of villi, but on the base of villi are the involved, then it is a tropical sprue. Okay, and here you can see the serological finding. So celiac disease shows the positive serology for anti-TTG, anti-EMA and anti-DGP antibody, but tropical sprue is always negative for this serology. The next disease is the autoimmune enteropathy. So characterized by the immune mediated attack on the intestines, leading to severe mucosal inflammation and damage, and it occur in the infant less than 6 months or in a young age. Okay, so autoimmune enteropathy can be a part of the IPEX syndrome. You know that immunodysregulation, polyendocrinopathy, enteropathy, X-linked syndrome. So what happen is here that anti-enterocyte, this is the enterocyte and this is the goblet cell. So antibody against this cell and this cell, this will destroy these cells. So it become like apoptotic bodies in the mucosa. So villus blunting and apoptotic enterocyte is the most common feature on the histopathological finding on the histopathology. So, and second finding is the loss of goblet cell. This is the finding of the autoimmune enteropathy. Next finding is the cryptitis and crypt abscess. So this is the crypt, and you can see here the abscess and the cryptitis. So histopathological image. So you cannot see the goblet cell in entire mucosa. Okay, these are the goblet cell. You can see, you can appreciate here these are the goblet cell, but you cannot see here any goblet cell. And you can see the lymphocyte neutrophil in between the epithelium of the crypt. Okay, so you can see here the neutrophil. So this is the crypt abscess and these are the cryptitis. So these are the feature of the autoimmune enteropathy. So next disease is the microvillus inclusion disease. This is a congenital enteropathy, and it is a autosomal disease, autosomal recessive disease, and occur due to MYO5B gene mutation on chromosome 18q21, affecting the myosin VB, acting dependent organelle transport and endosome recycling. So what happen is that endosomal transport is not occurring at a normal pace. So what happen is that this microvillus inclusion under the breast border, you will see on the electron microscopy or any special stain like PAS stain or ISC like CD10, then the anti-RAB11 ISC. You can see this microvillus inclusion in the enterocyte, which are the entrapped endosomes. Okay, so this is the most common cause of the mucosal cause of the watery diarrhea in infancy and requiring the nutrition support. So this is the electron microscopic image, and you can see the microvillus inclusion disease, the inclusion body here beneath the enterocyte, beneath the breast water of the enterocyte. The next is the tufting enteropathy, the cause of the protracted watery diarrhea in infancy. More common in the Middle East, high consanguinity regions. It is an autosomal recessive disease. Then is associated conditions like esophageal atresia, cloacal atresia, imperforated anus, dysmorphic facial features, and the non-specific punctate keratitis in 60% of case. So what happen is there, these are the tight junction. Okay, you can see the tight junction here. This is the normal villi, but here the tight junction are not seen because of the mutation of the EpCAM and Claudin 7, which makes the tight junction. Okay, so here the mutation of the EpCAM and the SPIN2 gene, which lead to the leaky tight junction. So that's why this connection, the form connection between two cells will be not organized, and it will make the tough villi. That's why called as the tufting enteropathy, and here the fluid will come out from the vessel and it will cause the diarrhea. Okay, so you can see here this is the EpCAM ISC and histopathological epithelial tuft, normal microvilli, and no membrane bound vesicle, because this is different from the microvillus inclusion disease. On TMA study, this electron microscopic study shows increased slender desmosome in the paracellular junction. You can see this is the classical finding here. This can be come in the your exam, NEET PG examination. So slender desmosome in the paracellular between two cells. Okay, paracellular junction. So this type of slender desmosome in the electron microscopy image, just write down the tufting enteropathy. Okay, next is the intestinal parasitosis. So you should look for the giardiasis, cryptosporidiosis, then the microsporidiosis, then the strongyloids, and the Entamoeba histolytica for the malabsorption syndrome. The next is the graft versus host disease. So post bone marrow transplant or rarely after the solid organ transplant it will occur. Incidence is 70% of patient post bone marrow transplant. Involvement of GIT and skin together in 24% of patient. Involvement of the GIT, skin and liver together in the 24% of patient. Chronic GVST means the graft versus host disease of the intestine in 30% patient of the post bone marrow transplant. So here are the 4 stage. So most common histopathological finding of the graft versus host disease enteropathy is the apoptosis and crypt abscess. Okay, so first is the grade 1. Grade 1 shows the occasional apoptotic body in the intestinal biopsies. Okay, grade 2 is the loss of individual crypt. So you can see here the crypt is lost here, and this is the apoptotic body. And grade 3 is the involvement of the more than or equal to 2 crypts with the apoptotic crypt abscesses. So crypt abscess you can see here, okay. And grade 4 is the large area of mucosa with the loss of crypt and mucosal ulceration. So you can see here there are no villi, just some mucous material here. So this is the ulcer look like on the histopathology. Then the drug induced enteritis or enteropathy. So 2 to 8% of subject receiving the various drug develop the enteropathies, like NSAID is the most common, PPI, proton pump inhibitor, lansoprazole, laxative, mycophenolate, and steroids, olmesartan, and all these will lead to some symptoms, similar symptom like the celiac disease, like lymphocytic colitis, then lymphocytic colitis, eosinophilic cell infiltrate, pseudomembrane, then the diaphragm disease, increase IELs, intraepithelial lymphocyte, apoptotic body in mycophenolate. So all these are the features. Next is the intestinal lymphomas. You should remember that maltomas, diffuse large B cell lymphoma, follicular lymphoma, mantle cell lymphoma, Burkitt's lymphoma, and some T cell lymphoma like indolent and autoimmune disease associated T cell lymphoma, all are associated with the malabsorption. Then the next condition is immunoproliferative small intestinal disease, IPSID. So geographical predilection is the Mediterranean region. Then histopathological features are the diffuse infiltration of the plasma cells and the para-immunoblast-like cell in the lamina propria on histopathology. And lymphocytic mucosal cryptitis you can see here, and types are 3. Type A is the mature lymphoplasmacytic cells up to the muscularis mucosae. Okay, so from the starting of the enterocyte till the muscularis mucosae, which is the part of the mucosa only. Then the type B is the infiltrate extending into the submucosa with the para-immunoblast around the mucosal crypt. So in between the crypts and also going below the mucosa, which is the submucosa. And the type C is the diffuse mucosal infiltration by large atypical lymphoid cells. So here the atypias come into the place and it will make the type C. So now we will discuss about the post-absorptive phase defects. So starting with the Whipple's disease. So Whipple disease occur due to the organism called as the Treponema whipplei. Okay, it is a gram-positive organism. Symptoms are like diarrhea, low-grade fever, weight loss, abdominal pain, peripheral or mesenteric lymphadenopathy, arthralgia. Okay, and it affects individual aged 20 to 80 years. Average age is 55. And here you can see on histopathology, macrophage containing T. whipplei in the various organ, like forming macrophage with the coarse eosinophilic granular cytoplasm stained with the PAS, periodic stain. Okay, so here the bullet shaped bacilli seen in the electron microscopy, and the chronic mononuclear and neutrophilic infiltrate in the mucosa. And you can also see the flattened mucosa due to the villi infiltration and distension. And also you have to differentiate this Whipple disease from the Mycobacterium avium complex, which is also showing similar histopathological features, and also from the fungal infection like the histoplasmosis. So for fungal disease you should do the agarofilic stain, which is the gomerymethamine silver, and for the differentiate from the Mycobacterium avium complex you should do the Zn stain, which is the Zilnensel stain, which will come negative in this condition, Whipple's disease. Next is E beta lipoproteinemia. So definition is autosomal recessive disorder of the lipoprotein assembly, transport and secretion. So symptoms are the steatorrhea, lipid malabsorption, hypocholesterolemia, deficiency of vitamin A and A. So what are the genetic findings? So first is the MTP protein mutation on the chromosome for Q2224. Okay. So MTP protein is responsible for the post-absorption fat transport and the absence of this MTB protein lead to the degradation of the beta lipoprotein B48 and B100. So this will deposit in the enterocyte, and in Anderson disease this only B48 beta lipoprotein is deficient. So what is the pathogenesis? So accumulation of large lipid droplet within the enterocyte cytoplasm due to failure in the transporting the triglyceride and the beta lipoprotein. So you can see the histopathological findings here. The large intracytoplasmic fat vacuoles identified at the villus tip, membrane-bound vesicles and chylomicron in the Anderson's disease, confirmed with oil red O stain on the frozen section and the Sudan black lipid stain on the paraffin embedded section. So this is the oil red O stain. And the last disease is the primary intestinal lymphangiectasis, Waldmann's disease, also called as the Waldmann's disease. So definition is the lymph leakage into the bowel lumen through the dilated mucosal lymphatic space. Affect children, adolescents and adults. Association with the von Recklinghausen, Turner, Noonan and Klippel-Trenaunay syndrome. Genetic would be genetic mutations are the VGF receptor 3, FOXC2 and SOX18 mutation. And histological findings like the dilated lymphatics, you can see here the dilated lymphatics in the mucosal lamina propria, patchy or diffuse changes potentially seen in the deeper submucosal or subserosal, and increase intraepithelial lymphocytes and villus flattening rare unless complicated. So these findings are rare unless the complicated. The diagnosis should be done on the upper GI endoscopy, which shows the whitish milky spots, white frost image or snowflakes. And technetium 99M labeled human serum albumin scintigraphy can help you to diagnose this condition. So thank you so much. You can subscribe my YouTube channel. I will come with new lectures, and I am just trying to improve that how can I deliver very nice lecture, very great lecture. So but I'm still trying, but please help me by subscribing my YouTube channel, liking this video and sharing it with the with your friends. Thank you.